Thank you, Mr. Chairman. With an estimated 115 deaths every day across America, 72,000 drug overdose deaths last year alone, and only 20% of people living with an opioid addiction receiving treatment, this is clearly a crisis that has yet to become a national priority. In Texas, overdose deaths nearly tripled from 1999 to 2014. San Antonio leads the state in infants born withdrawing from an opioid addiction, accounting for 1/3 of the babies born with neonatal abstinence syndrome. And drug overdose was the leading cause of pregnancy-associated deaths in Texas in recent years. San Antonio also had one of the highest per capita rates of overdose deaths in Texas. Each of these numbers represents a father, a mother, a son or daughter, a neighbor. In San Antonio, we have responded with a city-county task force with whom I've worked to secure federal funds to improve provider training and evidence-based prescription of opioids, increasing access to treatment options. The work that is being done there could be supplemented by the bill that we are considering today. We have across the country 32 behavioral health professionals available to treat every 1,000 patients with addictions. But in Texas, the number is much worse, only 18 providers per 1,000 patients. This legislation provides some opportunity for facilities in our state, including particularly the UT Medical School in the University of Texas Health Science Center in San Antonio. I believe the legislation provides an opportunity to expand some of the existing successful programs, and clearly the need is great. But the need is also great for additional legislation to add to what we're doing today. Outdated federal rules make it much harder for medical professionals to prescribe addiction treatment medications than it is to provide the powerful opioids that created the crisis in the first place. I'm a sponsor of the bipartisan Mainstreaming Addiction Treatment Act, a bill led by our colleague Congressman Paul Tonko that would eliminate the redundant and outdated requirement that practitioners apply for a separate waiver to prescribe buprenorphine. It's a mouthful to pronounce, but it is a safe and effective form of medication-assisted treatment for opioid use disorder that is already administered by physicians in office-based settings. Removing the additional registration requirement for prescribers has the potential to be a real game changer in terms of reducing overdose deaths. In France, for example, when this was done, making it available without a specialized waiver, opioid deaths declined by 79% over a 4-year period. The additional waiver that currently exists stigmatizes addiction medicine and sends a message to physicians that they lack the ability to effectively treat a patient with substance use disorder. By removing this outdated barrier, we can better integrate the treatment of addiction into primary care settings similar to how other chronic diseases are managed. Republican opposition to the bill we're considering today, the important Schneider bill, is particularly disappointing since their leader, President Trump, has been mainly talk and little action on the opioid epidemic problem. A few speeches, a tweet here and there, and promising to throw a few more people in jail will not resolve this crisis. Rather than calling for robust funding and laying out a detailed plan developed by drug policy professionals, he's entrusted the entire effort to Kellyanne Conway, a political advisor with no drug policy experience. What we need is less talk and more action like that Mr. Schneider is proposing. This problem will not be resolved without such specific action. We're only 2 weeks away from the Trump administration's effort to take away before the Fifth Circuit of Texas our protection for pre-existing conditions. This also is a matter that is essential to dealing with the opioid crisis. I hope it can be resolved in favor of pre-existing conditions.